quality and patient safety improvements. We are here in this webinar to let you know about how to overcome some of the challenges and how to find answers to your questions. I can see the number of participants is still growing on my screen, so I'm giving it 1 more minute before we actually start. Today's webinar is number 19 in our series of webinars, and we started 2 years ago in fall of 2019. We carried the webinars alive through the pandemic, and we helped to respond to the pandemic and to organize post-pandemic operations. And we found out from you that the questions, that the issues that we are talking about are even more important during those difficult times. So we decided that the webinars should be run approximately once a month, and they cover the issues that you tell us about. We listen to your feedback. If you provide us with feedback, we'll listen to it. We try to answer your questions. We try to address your concerns, or we are very happy if you share that you are using the knowledge that you learned in our webinars. This makes us very happy, and we are happy to continue to work, to continue to organize webinars, organize assessments, share our knowledge in publications, in our Facebook group, in our LinkedIn channels. So this all comes from you, and you are our encouragement. So before we start the webinar, I'd like to ask you to please submit feedback either at the end of the webinar or by contacting us. You will be responding to, you will be receiving an email tomorrow with the slides and with the links to all the resources that we talk about today. Now, one important announcement. It is important to put your email correctly in the registration. If you make a mistake in your email, then the email tomorrow will not reach you and the slides will not reach you. So if you are, when we see something like Gmail spelled incorrectly, of course we can correct that, and we can still send you the slides and the thank you email. But if you misspelled the first part of your email before the @ then it's difficult for us to guess sometimes what the correct version should be. So please check that if you're not receiving an email from us by tomorrow night, then please contact us in some other way. Or if you realize now that you misspelled your email, then please, you can still go to registration and you can re-register. Even if you do not even have to log off, you do not have to disconnect from this webinar, but we will be receiving the correct email that you have, and we will be sending our materials to your correct email tomorrow. So once again, we welcome our participants to IPSG Healthcare Quality Webinars, and this webinar is number 19 in the series of webinars. One important topic is how to use the interpretation. In Zoom, below to the right, you have the interpretation button. When you press on it, you have the channels that are available today. We have Arabic, French, and we have Russian. So please go to this button and select the language that you would like to listen to the webinar. Now, this is only available in Zoom, and this will not be available in the recording of the webinar. So please switch to the channel that you'd like and make the most of our webinar. So this is the function that comes first to some of our participants, and we are very happy to welcome our Arabic-speaking participants, our French-speaking participants, and our Russian-speaking participants. Thank you for joining, and we are trying to do whatever we can, and our interpreters are trying whatever they can to make the webinar useful for you. We are using the best interpretation possible, but we could not, I mean, our interpreters did not have time to graduate as medical doctors. So if there are some important issues that do not get translated or that you do not understand, please send us a message or write in the chat or let us know otherwise, and we will try our best to repeat or to explain the matters to you. I'm walking you briefly through the history of our webinars that started in October 2019. We started with covering the quality culture and the international patient safety goals and some other issues. And then we moved into the COVID-19 pandemic, and there were some webinars related to COVID-19 response. We realized at that point that quality and patient safety issues are even more important during those times. And so we continued to, with more specific issues, we had some webinars dedicated to laboratory and to radiology safety. We discussed clinical guidelines and the experience of your physicians and what could go, how both could be used to the greatest benefit of your patients. So we talked about sterilization, we talked about staff engagement, because by that time, by June 2021, our clients realized that their staff are getting more knowledge, they are getting more knowledgeable, and they are thinking about finding places to apply their knowledge. So staff engagement came very handy. We talked about policies and procedures, how to create them and how to implement. We talked about infrastructure, because some challenges, you cannot just rebuild the facility where you're at. It's not always possible. Some of our clients are expanding into new facilities and they're adjusting the facilities to their needs. But what if you, they are building the facilities to suit their needs, but what if you have to adjust your facility to what you're doing? So that was a webinar in September. And finally, in October, we had the part one of the hidden complexity of implementing patient safety goals. So today's webinar is the continuation of this topic, how to overcome the challenges in implementation of patient safety goals. And today we are talking about safe surgery, we are talking about the management of high alert medications, and we are talking about the effective communications. So all three are very important. Let me walk you very briefly through our resources. We have our website, that is IQ Healthcare webpage, and you will be receiving a link to that in our tomorrow's email. We have a dedicated page that is called IQ Healthcare Webinars and Trainings, and this is all under our IFC platform. We have a Facebook community of practice that is called IFC Healthcare Quality Community of Practice. This is a closed Facebook group, and we welcome you to join it. You please send us a request and to join the group. And it is there that we exchange opinions, that we publish information, and this is where you can find additional resources. Now, we also have a YouTube channel where at the moment you can probably see my face and see this presentation. And this is because on that channel, the presentation goes live. Okay, this is our, one more important function is our questions and answers function. If you go to the bottom of the screen, you see Q&A, and you press on that button, and you can ask a question in the chat. Unfortunately, it is not possible for us to provide you with an opportunity to ask questions live because we have a lot of participants. So if we will not have enough time to listen to all of you. But you can type your question in Q&A and we will be answering it in the chat. Also, we have a chat that is for questions and answers, but also for your notes, for your requests. For example, like, I did not hear this. Can you please send me a link to the to where the recording will be? And actually, the recording will be available immediately after the webinar on our YouTube page. So please don't miss that. At the end of our webinar, there will be a survey on exit, and we'll ask you to answer 3 questions to tell us how useful this webinar was and how you liked it. And you can also send us an I'm satisfied email. Tomorrow you'll receive a link to generate such an email, and you can tell us any comments. I mean, today or tomorrow you can share with us any comments on how you will be using the knowledge, or why you will not be using the knowledge, or what else you'd like us to do for you to obtain additional knowledge. So we rely on your feedback. We greatly appreciate you giving it. About the training, that one more very important resource we have on World Bank Group's OLC, Open Learning Campus, olc.worldbank.org. And this is where you can find our training modules that we will be partially covering today. Today, there are 7 of those modules available. Here is the link, here is the list of those modules. And this is where you can receive a certificate of attendance, certificate of completion. Now, unfortunately, we cannot provide certificates of completion for our webinars. We do not have the authority to do so. But OLC can provide you with a certificate for completion for any of those training modules. And they're comprehensive, they're up to date. So please complete so once you complete the course, you go through the course evaluation again to tell us what was good, what wasn't good, and you can generate a certificate into your name that you can keep and present as your additional qualification. And now we receive a question every time if it's possible to receive the certificate of attendance for our webinars. Unfortunately, it's not, but please, it's possible to receive a certificate of completion, which is more valuable for our online courses. And with that, I'm passing the floor to Julia, our expert in quality and patient safety, to present the speakers of today's webinar. Julia, over to you. Thank you.
Thank you very much, Natasha, for this wonderful introduction. Good afternoon, good morning, good evening, everyone. Welcome to IFC series of webinars. Today, let me remind you, for those who recently joined or are joining now, because I can see numbers are still changing, still growing. Today, we are discussing international patient safety goals. This is the second webinar which is devoted to this subject. The first webinar is available on our IFC internet webpage, and you can watch the recording there. And today we are discussing the 3 goals. Specifically, they are safe surgery, effective communication, and high alert medications. So we have our experts today. You will shortly listen to their presentations. In the second part of our webinars, as usually, you will get a chance to ask questions. So this is a unique chance. If you have any questions related to the implementation of these 3 international patient safety goals, if you are already in the process, you can ask your questions on adaptation of these goals, on correction of these goals, and we hope it will be useful. Today, we are going to discuss such issues as what is the way to adapt the safe surgery checklist, how to overcome challenges connected to the implementation of safe surgery checklist, what is effective communication, and in which areas we are talking about increasing the effectiveness of communication, where is it specifically important, and of course, high alert medications. What are such medications, how to mark them, and what are tips on the safe storage, use, and administration of these medications. So let's discuss all of this today. Please feel free to ask your questions. And now we move to the first speaker. I'm happy to welcome Jackie Stewart, the CEO of COSASA, that is Accreditation Council from South Africa. Jackie, the floor is yours.
Thank you, Julia. Thank you, and greetings to everyone. It's a real pleasure to be here. Let me just sharpen sharing the screen. Right, so thank you. So as Julia said, I'm Jackie Stewart from South Africa, and I'm going to be talking mostly about high alert medications. And what I decided to do was to use real examples of adverse events that have happened with high alert medications. So I'm just going to talk you through those. So the first one, this related to a newborn baby. It was born at 1900 hours on 7th of April to a normal delivery. The mother was transferred to the postnatal ward. And in the early hours of the 9th of April, the baby was admitted to the nursery with severe dehydration and respiratory distress. And I just want to pause at this point because I think it's important often when these events happen that although it is talking about a high alert medication, why was the baby admitted? What happened? And one of the things that came out in the root cause analysis was the failure of midwives to monitor the baby properly during that period with the mother. So once it was into the nursery, the doctor saw it and gave her a fluid bolus of normal saline at 10 milligrams per kilogram. There was no improvement there. And then he gave a further bolus of 5 milligrams per kilogram normal saline, and the tachypnea decreased and the oxygen saturations were maintained by nasal prongs. So baby then seemed to be reasonably stable. The doctor commenced a rehydration of neonatalite at 5 mils per hour, and he checked that the fluid dropper was correctly set before he left the nursery. At 8:30 in the morning, so just 4.5 hours or 4 hours later, he was notified the baby was desaturating and had no pulse. The registered nurse in the nursery started CPR. The doctor arrived, intubated the baby, and found that it had an enlarged liver, crepitations in both lungs, and he found the fluid dropper to be fully open. So the baby had been given 200 mils of fluid instead of 20 mils in that time. Baby was in cardiac failure, had pulmonary edema, and sadly the baby later died. The real challenge on the root cause analysis on this was the nurses denied touching the fluid dropper at all, and the mother was not present. She was sleeping and was not in the nursery. I think this highlights a number of challenges in why these things happen. Were some of the nurses not aware that 5 mils an hour, and with tiny babies, these medicines have to be administered at such careful dosages. But the important part of all of this was the learning, and what is difficult to extract when you just get the report like this until you do the root cause analysis, and I can't show you the detailed root cause analysis in the time, but there were some interesting issues, and one of them was about communication, because the doctor checked that the fluid dropper was correctly set, but he didn't communicate that to any of the nurses, although it was prescribed at 5 mils per hour, and they should have followed those instructions. But we're talking at 4 o'clock in the morning, there should have been more communication. If nurses were uncertain, did they check, was there somebody with the baby all the time? Clearly there was not. Did somebody feel the need to give the baby more than at the time? So it was a very, very tragic case. And at a time when, a mother should be very happy. But as I say, there are stages in this incident where the maladministration of the drug was the major problem, but the steps along the way as to why this happened, and one could argue the baby should never have been needed to have been admitted had the feeding been monitored more closely. So I think it's important when we're looking at these things to ask the questions why, but also at each stage, what is the learning? But we can't just blame people, go, it was that nurse or that midwife or that doctor that was wrong. What actually happened through this process? You know, a baby that unable to speak for itself, unaware. So there were some tragic steps, but it was all just under the high alert medication, the use of electrolytes and glucose for babies. And I think it's important when we do our root cause analysis that we unpack all of the causes and go, what do we learn? Not who's to blame, what do we learn? And how do we make sure these things are passed on into others and the learning continues if other cases emerge. Okay, so now the other end of now, that was the beginning of life. This is an elderly gentleman again. It's a high alert medication. It was a 90-year-old man who was admitted on the 23rd of February with pneumonia and heart failure. He was seen the following day by the doctor, and his blood test showed hyperkalemia. So a potassium level of 2.5, which is very low. The doctor prescribed 3 medications, actrapid, kylexolate, and calcium gluconate, all medicines for hyperkalemia, medication to reduce the potassium. When the doctor left, the nurses gave the medication without querying the prescription, and the patient's condition obviously became more unstable because his potassium levels were dropping quite dramatically. Ultimately, the medication was changed and the patient did recover. But again, I think it's a very important one. And interestingly, in this case, there was no root cause analysis undertaken. So we've been left, if you like, to interrogate the information ourselves. And was it the case that the doctor made an error? Was he tired? Did he genuinely misread? Was it lack of knowledge? Because it's a pretty fundamental mistake to prescribe the directly opposite drugs for the condition. The other question one has to ask is when the nurses gave the medication, they didn't query the prescription. Now, most experienced nurses would know what medication is intended to do. So my question would be, did they have a lack of knowledge? Or again, have we got a communication issue where they were unwilling or didn't feel able to challenge the doctor? And I think those are important questions because if we're going to improve the safety in healthcare, we have to be able to challenge each other. Whatever profession we are in, whatever position we're in within the organization, we have to be able to challenge. And I think that is a fundamental in terms of patient safety. And I think it's a fundamental when we come to implementing the international patient safety goals, that we have to have a voice to be able to speak up. So those are 2 examples of high alert medication. And I'm going to talk a little bit about safe surgery, but I'm going to do this from a very personal experience. Before I start though, I'd like to ask those of you watching this webinar, if you could just put in the chat box, yes or no, have you ever made a mistake in your clinical practice? Please be honest. I'd like to see some of what we're getting in the chat. Oh, good, I'm seeing lots of yeses. I'm seeing lots of yeses. Okay, thank you. Thank you. I think that proves my point. I don't know if any of you have done this at home, as it were, but I often ask this question when I'm doing training on patient safety. And generally, the room is silent and nobody raises a hand. So I'm always the first one to go, Yes, I have. I have. And I'm just going to tell you because it kind of relates to it does relate to safe surgery, but it happened to me in just about the end of my first year of nurse training. I was working in the outpatient emergency at the hospital at which I was training, which is a large district hospital. There was a patient came in for a reduction of fracture in the minor ops room. And the sister said to me, "No, Stuart, please clean the patient's arm with iodine." We're talking about a while ago. Okay, I changed quite a long time ago. So I looked on the cabinet and I saw a bottle and I saw IOD. Perfect. This is what I need to do. I poured it into a galley pot and I started to clean the patient's arm. And as I started to clean his arm, blisters started appearing. And I was like, what's going on? I don't know what's happening. The sister came in, she said, "What are you doing?" I said, "Well, you told me to clean the patient's arm, but look, he's getting blisters." I was cleaning the patient's arm with iodized phenol. I can smell phenol at 1,000 paces to this day, but I am eternally grateful to the doctor and the senior sister of the department because of the way they handled that incident. The doctor immediately said, "Right, let's put it away. Let's start cleaning this, sorting the arm out." And as he was doing it, he was explaining to the patient what had happened. And he said, "Besides your fracture, you're probably going to have to come back for a couple of dressings because unfortunately we have managed to burn your arm." The patient was treated, the reduction of fracture was done, and the doctor turned to me after and said, "Are you okay?" And I was bemused because, and the phenol, iodized phenol had been left there from a previous procedure. It shouldn't even have been there. But as a student, I didn't know, and I didn't know to ask. I didn't think about turning the bottle around to check, which I've now learned is what you do. But it was one of those cases. And then on the Monday, this was over the weekend, on the Monday, the sister in charge of the unit sent for me and she asked me what happened. And I told her. She asked me where the sister who was on duty was at the time that I was doing the cleaning. And I told her. Nobody raised their voice. Nobody told me I was wrong. They explained what had happened. The sister was not sanctioned in as much as blamed, but was advised and counseled about how to supervise students in future. And it made me so alert to the possibility of things going wrong. How many other nurses, if that had happened and the handling, or even myself, if the handling had been different, would maybe have given up their career? It wasn't a life-threatening incident, but it was a serious enough incident to really make me take stock. So I just wanted to share that because I think often we think it always happens to other people, or we don't want to talk about it, we don't want to share. And I think it's important that we are able to speak out publicly about what we have and haven't done, and importantly, about what we've learned from it. So I will pause there, and I know there are excellent presentations coming from my other two colleagues. Thank you.
Thank you so much, Jackie, for this wonderful presentation, and really lots of lessons we can learn from what Jackie has just told us. Number one is, and this is actually a more general thing, it doesn't only relate to the international patient safety goals, but proves that why they are so important. That is because each mistake, sometimes with serious consequences, happens as a result of the worst case scenario. And this was really clear in the examples that Jackie provided. Lots of factors contributed to these drastic mistakes taking place. Speaking about the importance of differentiating high alert medications, for example, and storing separately look-alike and sound-alike medications, actually there are lots of examples which take place in hospital settings, and I'm an expert in healthcare quality. I usually go to different facilities and spot the mistakes and tell the teams how to correct these mistakes. But unfortunately, even in my life, there were mistakes, speaking about making mistakes, even not in hospital setting, but in home setting. Once I confused shampoo in an absolutely similar bottle with a liquid based on acid for cleaning table silver. And fortunately, I didn't put it on the hair yet. I just put it on the skin, and I felt that something is not right. But the bottles looked absolutely alike. And I made this terrible mistake of storing them together. I was in a rush. I was really not paying attention to what bottle I was taking from the shelf in the bathroom. And this was the result. I can't even imagine what would have happened if I applied that acid to the hair. So unfortunately, this proves that it can involve each of us in the hospital setting, in any area of hospital, and even outside the hospital. These skills are useful. That's why we pay such attention to the international patient safety goals. And let's listen to our next speaker, Dr. Zinat Khan, and from Aga Khan University. Dr. Zinat, please, you're welcome with your presentation.
Thank you very much. Listening to my colleague earlier and some wonderful examples she gave, I would like to build upon the same. Before I do that, I would like to thank IFC organizers to bring all of us together to talk about such an important topic, i.e. patient safety, and related to that, the international patient safety goals. I bring very warm welcome from Tanzania to you all. Moving forward to the hidden complexity of implementing patient safety goals, I would like to share some of our experiences. It's the whole system where I work in East Africa, where we have diligently made efforts to implement our patient safety goals as a priority at the Aga Khan Health Services in East Africa, where I work. We all know that the IPSG, they are extremely important for us to target in our settings because they have very strong evidence-based and expert-based consensus on the sentinel events which have happened in the past internationally. We just learned or heard about them from Jackie earlier, that these are the sentinel events which could be really disastrous for the patients and also for the caregivers like all of us who have managed that and have been the second victim in these sentinel events. So it's important that we promote specific improvement strategy in these patient safety goals. So how and where could things go wrong? And I was looking at the chat, and it's interesting to see people talking about, maybe if the neonatal nurses were taking care of that baby instead of midwives, the outcome could be different. Was the baby in an ICU or was the baby in general ward? Maybe the outcome could have been different, and so on and so forth. What are we talking about? We are all talking about how to look at international patient safety goal and the related issues in a bigger picture of system approach rather than looking at that small area. And that's what I want to talk about as we go along. What is the culture of safety in this organization related to patient safety goals? And we heard about culture of safety. Do we nurses and doctors and technicians, do they feel safe enough to speak? Is leadership giving enough attention to patient safety goals or the issues? Do we have enough resources? Is there the essence and spirit of multidisciplinary team? Training, are we giving enough training? Are the right nurses, right people, right staff in the right place? And there are so many others. I have just picked some key ones, and so many others which could really, if aligned, could avoid sentinel events as we go forward related to patient safety goals. And as we go along, I will talk about, so what are the aspects we need to bring together in order for us to ensure that the true spirit of IPSG implementation happens. There is no magic wand at all. There are multiple ways of dealing with it. You and us, we as healthcare providers, as leaders, as quality leaders, nursing leaders, physician leaders, need to work together and look at any implementation in its totality. Instead of having knee-jerk reaction of picking one thing or the other, we need to put our heads together to look at things in totality. And I will talk about this again with some examples as we go forward. Let me pick up the improving of effective communication. We all know that effective communication, one, which is done in a timely manner, which is accurate, complete, clear, and understood by the recipient, is the true effective communication. And that is not in just healthcare, but it is everywhere in all walks of our lives. We also know that numerous sentinel events have been due to poor communication. So really, many errors and sentinel events can be reduced if we work towards our communication. There are three key communication improvement which I would talk about in terms of healthcare setting under IPSG: verbal and telephonic communication. Many times we pick up doctors and nurses are having, or doctors and multidisciplinary teams are doing communication via telephone. How do we ensure that we are doing that effectively? Critical values could be a major activity and a common activity which happens where clinicians have to immediately respond and do treat the patients. So if the critical results are not communicated well, which could lead to sentinel events. And also handovers. Handoffs are very common between nurses during shifts, doctors, referrals with the doctors, and during interdepartmental level. So these are some of the areas where we talk about effective communication, and the systems need to be put in place for us to avoid those errors. Communication is the least expensive weapon to avoid. The resources required in doing clear communication could be very minimum. Of course, we can go very sophisticated with gadgets available in the market, but really writing it clear, speaking it clearly, documenting it clearly could really be the outcome could be changed by doing that. And some of the things which we keep talking about: write legibly, speak slowly, repeat, write down, confirmation, avoid abbreviations, and so on and so forth, is so important in order for us to avoid such incidences. When it comes to implementation of IPSG-2, I have seen within our system and around the world when I go and visit that, and I want to reinforce it, two things which are very important. Please do not try and implement the communication, effective communication, for the sake of doing documentation. Doctors and nurses have enough to do. Let us try and keep it simple. Let us not try and make people write for the sake of writing. We need to do documentation which is important, which is crisp, which is needed. So let's keep it simple. Let us not keep it as a desktop. Somebody sitting in an office making a policy is doing that a policy which says that a doctor needs to write this. No. And that's a pitfall, which is a major issue on the ground. The more we are making people, our clinicians write, they're staying away from the patient care. But what we want them to write should be clear, concise, without abbreviation, and thoughtful, etc. I find SBAR to be a very logical tool which we are using in our system, where write the situation or speak about the situation, give the quick background, give the assessment, let's get the recommendation or orders, etc., and so on and so forth. So putting up systems such as SBAR, we have found to be more useful than having a big documentation form and make people write about it. Culture of safety. I cannot emphasize that enough. If we are doing critical values discussion on the phone, or we are writing on a ledger, or if the doctor is giving a verbal order, and if we do not have, we have not instilled the culture of safety for the pharmacist to say, hold on, doc, I don't understand this. Or for the nurse to say, doc, what do you mean by, did you see atropine or adrenaline or so and so forth? Speak up is extremely important in order for us to avoid such communication issues. Let us look at our policies and document it. It is important that, and I talked about it, keep it simple, ensure that the key elements of communication is there. In a critical value, let us be clear that we want individuals to write down, read back, and seek confirmation. Look at the standardization. When you go to a hospital where one ward is using a loose piece of paper, the other one has a ledger or a register, the third one is putting a sticker, we are confusing our staff. Let us try and standardize our policies and procedures. Leadership must take an active role in implementing these standards across the board, and ensure that we all understand that everyone is responsible. It is not just the nurses who are documenting, or the lab people who are looking at the critical values, but every one of us is responsible. And that is where the communication is so important. Training is so important. Leadership is so important for us to again and again reinforce. Let me take you quickly through high alert medications, IPSG, the HAMs. Again, we just heard wonderful examples of actual sentinel events related to high alert medication. And that is exactly what I'm talking about here, that the injuries can be fatal, the injuries can be permanent damage, and it's not just for the patient, it is an absolutely devastated for the staff, and we are the second victims for these sentinel events. Some of the high alert, when we talk about it, is related to the medications who can really affect us, such as hypoglycemic agents, such as adrenergic antagonists and antithrombolytics, etc. Some of them are just look-alike, sound alike. They just, if we make a mistake on that, whether we are on the phone and it takes us back to the effective communication, or we are writing, if we are not properly communicating, the look-alike and the sound alike could become a major issue. So see how well the high alert medication and the communication is coming together in this case. And of course, concentrated electrolytes, we just heard, could be extremely important. So who is responsible in this? Many times I've heard, oh, it's pharmacy because it's medication. The first answer is, it's pharmacy problem. Let them manage it. Oh, I didn't know that. But let us look at it. No, it is everyone's problem. Like we talked earlier, the doctors who are writing the order, and we just heard about it, the doctor's orders. If the doctors are writing the orders, but if the pharmacy staff are dispensing, or if the nurses are dispensing and preparing, then they are equally responsible to pick the problems. If pharmacy has dispensed by mistake, nurses are preparing, nurses are administrating, we have the third place where we can pick. So it's not one person, it's the team which is important. The doctors, the nurses, the pharmacists, they are all important to pick it somewhere in this line of system. A lot of times systems of our storage help. How are we storing look-alike and sound-alikes? How are we ensuring that our high alert medications are appropriately labeled, and so on and so forth? The label being used in pharmacy could be the label used in the wards, and so on and so forth. Leadership. I cannot emphasize the importance of institutional leaders to make IPSG, and in this case, high alert medications as the priority. Give appropriate resources, educate the staff, encourage staff to report, and also work towards what is the issue and how do we improve upon it. The HAMS risk reduction is really the whole system of medication. Ordering from the physicians, verbal order or written order. Have we told our physicians, have we trained our physicians how to order a look-alike, sound-alike? Have we talked about how do they write the actual milligram or milliliters and milligram per hour, etc.? Storage. Very important. It is not just pharmacy, it is across, including the warehouse, when it comes from warehouse all the way to the nurses. When the nurses get it, what is the storage policy? Preparation. Have we given a preparation place? First of all, high alert medication. Are we giving all of them to the nurses in the unit to prepare? Sure, if that is what we have as an institution decided. Have we trained nurses? Do they understand and the risk related to it? Labeling, I have talked about. Administration, again, is our policy saying that if there is a high alert medication or concentrated electrolytes, the administration will be done by double checking of 2 nurses, by going bedside with 2 people, and so on and so forth. So again, this is a system issue. It is not one doctor issue or a nurse issue or a pharmacist issue. It is a system issue which you need to look at. We all don't have to reinvent the wheels. There are so many tools available which could tell us how do we start and where do we start from. In my own system, we started by putting up a committee, which we call it a Pharmacy and Therapeutic Committee, which is a strong multidisciplinary committee. And in that committee, everyone has an equal say. And I'm so proud to see, yes, our pharmacy is taking the lead, but our physicians, our nurses, our warehouse people are also part of that, who are giving input. There are many evidence-based lists which are available, which we started with and looked at it to see what are our institution list of high alert medication. We made those, we made policies related to that. Education, education, education. I cannot emphasize that enough. But that's not enough. Then comes the importance of reporting. Remember, when a patient gets hurt, a sentinel events happen. That is a reaction reporting. There are so many things we can do as proactive reported by pharmacy interventions. How many times pharmacies are calling the doctors and asking them to clarify the look-alike, sound-alike, for example. These are important interventions. We should report, we should analyze, and we should learn from it. The same with doctors, the same with nurses. The more near misses reporting we do about high alert medications in all the processes, from ordering to dispensing to preparation to storage to administration, the more we avoid, the more we learn, and so we can do better and better. It is also important that these are disseminated to teams. In our case, our pharmacy takes the lead with our physicians, nurses, and others. They present to us the data. We learn from them. We look at our policies. We alter our policies if need be. But that is the gist of it. Not making a paper policy and keeping it on the table, but always ongoingly looking at it. Our pharmacy and nursing team takes such active role in going and checking the storage. Are the labeling done appropriately? Have we kept it into the right shelves according to our policies, and so on and so forth? So these are some of the important things which helped us to do that. A lot of times, we also started in our system coming up with the red and the blue and the yellow labels and putting it on the vials and taking away the hiding the expiry dates, and all of us were doing this, that, and other. And then with time, we calmed down, we figured out what are the rights and the wrongs. And once again, pharmacy plays extremely important role in guiding us. And now with time, we have figured out how to store high alert medications. Do we need to keep it alphabetically? Should we keep it categorically? In the wards, when it comes to nurses, how are we informing them? What kind of appropriate labels and stocking we are doing? What kind of good training material we are keeping? I love this exciting neat and clean. It is not the clean spelling we say, but neat, clean is such a wonderful phrase for high alert medication, which talks about which are those, and so on and so forth. And I'm sure your institutions have a lot of these things as training and development. This is an example, and yes, we have some of our institutions have electronic, but some of us don't. So look alike, sound alike, the tall man writing, we are emphasizing it for our doctors. We are emphasizing it for our pharmacists to pick it up and report if we are not doing it. But more and more IT is coming in. So let's look at how we can utilize the technology to help us by giving high alert medication reminders to the doctors, to the nurses, and so on and so forth. So do work with the technology if it is possible for you to do it. If not, it can easily be done as long as it's part of your system on a written document as well. That is how we started in terms of our document. Not just in doctors, it is also where we do it for our pharmacy. Our pharmacists, when they are doing the medication dispensing, we also do this, and as you can see, we get a warning, LASA, and so on and so forth. So there are many things which we can do and bring things together in order for us to avoid such sentinel events. So these were some of the things, activities which I wanted to share with you and really show you what we are doing in our institution and how we work around it. Are we saying that we have no sentinel events? Absolutely not. We still have sentinel events. We have adverse event. It's the leadership commitment. It's the multidisciplinary commitment of putting appropriate structures, putting appropriate policies, improving the culture of safety, developing champions. Like I talked about in HAMS, the champions are the pharmacists and the nurses, etc. This is how we have dealt in our organization some of these challenges related to IPSG implementation. I will stop here. Thank you very much for listening.
Thanks a lot, Dr. Zinat. Lots of useful tips. Thanks a lot for all your advice and all the lessons that you learned from your practice. I just wanted to quickly sum up what Dr. Zinat just said, some important facts and some important takeaways. So number one, of course, is the team approach. And that's the essence of the whole patient safety principle is we work together in order to help each other. We help each other by double checking after each other. And as Dr. Zinat said, at certain level, if you work as a team, somebody will spot a mistake. So this is additional instrument for mistake prevention. Second important point is about no shame, no blame culture. And Jackie earlier said about it, about the importance, about the attitude of the doctor to the incident which happened to the patient. And only in this case, staff will be able to speak up. So now you see that in quality and patient safety, everything is interrelated. So no shame, no blame. It means that staff are able to speak up. It means that if they don't understand, if we're talking about effective communication, they check again, they ask, they say that I didn't understand. Can you please repeat? If a nurse is afraid to speak up because the doctor will say, which happens, even happened in my practice, are you deaf? And in this case, you just kill all initiative and the nurse will be scared, and being scared, she will make even more mistakes because it's stress. So basically, key facts and key approaches to all the international patient safety goals implementation, they are more or less the same. Speaking about effective communication, identify the areas when it is required, like handover or verbal communication or critical test results, and then think together as a team how you can use it in your specific facility, because there is no one-size-fits-all solution, of course. Same. And it's critically important in emergency. So the higher the speed of work and the more stress and unpredictable situations, the more risk for communication mistakes. Speaking about high alert medication, same principle. Identify the areas, identify the medications, and identify the areas where you work with these medications. Together as a team, decide which will be the best practice for your facility, how to make sure that they are not confused and checked by somebody else while being administered. And we will discuss this during question and answer, of course. Now we move to the third speaker, Dr. Ajibike Oyewumi, and those who join us not for the first time definitely met Dr. Ajibike before, and also maybe met her personally during the assessments because she's part of our team. So Dr. Ajibike is a certified healthcare professional. So Ajibike, you're welcome with your presentation.
Thank you very much. Hello, everyone. I think this is where slideshow is. It's been covered. Oh, okay, there you go. Hello, everyone. Julia, can you hear me?
Yes, we can hear you.
Excellent, excellent. Thank you very much. Good morning, good afternoon, good evening, everyone, once again. Always a pleasure to be here to continue the journey, we all are on to improve patient safety, to find ways of making the dream come alive, the reason why we all gather, the reason why we all go to school to get into healthcare. So I'm going to be talking to you about two areas. I'm going to talk to you about surgical safety and a bit about effective communication. But before I dive into those, I want to, reiterate something that Zinat said, which is, please do not make people do tasks for the sake of the task itself. Do not make people write out SBAR just for the sake of documentation. Do not create your policies and procedures just because COSASA says so, JCI says so, the national standard says so. You need to always think about the why and communicate the why to the people who will be doing this work. When we understand everybody very clearly why we're doing it, why are these policies being set up even by leadership? Why is leadership saying we need to have policies around implementation? Why must we do the surgical safety checklist? When we all understand the reason, about keeping the patient safe, about the fact that and we make mistakes. When we all understand that, I believe that it would be easier to implement and sustain, to have people do what they need to do properly. So please, if you remember nothing of my talk, please remember, start with the why. The how and the what will come, right? As I said, imagine if Martin Luther King said, I have a plan rather than I have a dream. How many people would have followed him? So always think about why you're doing this, the safety of the patient. So I'll then quickly dive off. I'm going to be talking to you about two aspects. Like I said, never mind the order. I'm starting out with ensuring safe surgery. Now, is it as simple as a checklist? I hear surgeons say that to me all the time. Is it as simple as a checklist? I mean, what do you think your checklist is going to do? My answer is yes and no. No, in the sense that, of course, if you do not have the skills to ensure that you can do the surgery well, you have no business being there in the first place, right? So is it just about the checklist? No, it's about people, it's about the surgeons having the skill. We've made the right diagnosis, where the hospital has the resources needed to perform the surgery. That's a given. But beyond that, can it be as simple as a checklist? Largely, yes. And the reason is the why of the checklist. The checklist has been developed as a tool, a reminder of tools, of what needs to be done. It's been developed as a reminder of things that we do all the time that may become rote, such that we forget. It's been developed as a reminder of things we don't do often enough, so we may not remember. It's been developed as a reminder for people like you and I who are so busy and already thinking about the next case. And because you're human, you may skip certain things. So is it as simple as a checklist? Yes. This checklist packs a wallop. There's so many things in there that help you to deliver the surgery safely to the patient. Research has shown that the surgical safety checklist actually helps to reduce inpatient mortality, right? Post-surgical deaths. It's been proven to reduce the need to take the patient back to the theater because something has happened, because we've left an instrument or a swab inside, because we've communicated about what's going on there. We've all worked together. It's been shown to reduce the incidence of surgical site infections. Okay, and what is it about the surgical safety checklist as a problem? I'm sure everybody on this webinar today knows something about the surgical safety checklist. What are the problems? We hear, oh, it doesn't work. The pitfalls really are: one, the failure to engage the frontline staff early to help them understand the why, like we've said. Why are we doing this? Whether you're using data, the stories of patients that have come to harm, even the near misses that we had in the past that we were lucky that we need to be able to catch next time. The failure to consider your visiting surgeon. So, I've seen that in a number of hospitals. The surgeons that are in-house or the staff that are in-house use the tool. But at the time that it was being implemented, we forgot that there were people who do not come regularly and we do not communicate with them. And then it becomes a major struggle in the operating theater or in the emergency room for the nurses to get these visiting surgeons to use it because they don't use it in their own establishments. Failure to own the checklist and incorporate it into the existing context. I've seen, I've heard surgeons, I've heard staff complain that, look, we already checked this things in another checklist. So why are we double checking? We've checked it, when the patient came in, I checked the consent form. Then we checked the consent form on another preoperative form. Now we're checking the consent form in another way. Well, two things. One, we need to consider how we own the checklist and make it work for our organization. It has to become our own. This is how it works with us. However, on the other hand, over-adaptation to the point where you lose important elements can be an issue. So if we decide to take away the informed consent part, for instance, because we already have it on another form, that might be danger. So please consider it. But over-adaptation can be an issue. Sometimes we over-adapt on the other side. We put in so many elements that it takes the team almost 10 minutes to complete it. And the surgeons are pushing back and saying, I don't have time for this. So we have to find a balance about how we adapt the tool. We assume that the staff know what to do. So the management sits with the quality department folks and they come up with the checklist. And then you push it out there and say to them, go forth and do. That is an assumption that doesn't always work, because even though it looks simple, yes, it's not always as simple as it looks. Failure to test the process before implementing it. How does it work in our own organization? Do we need a board for a reminder? Who is going to do what? How do we do this in a way that works? So the first time we do it, we might do it and it's not working very well. Adapt it. Test it, use it, test it till you find something that works for you. That failure to test, just taking the WHO checklist, for instance, hook, line, and sinker, and just dumping it into your system may not always work. So think about how this will work for us. Who is going to do it? Who is going to champion it? Okay. The other problem we see is failure to consider and include all areas. So in my experience, what I'm seeing is many hospitals use it in their operating theaters, but they don't use it in other areas of the hospital where they do procedures and there could be mistakes. So they don't use it for emergency procedures in operating theaters. They don't use it in radiology where they have interventions. They don't use it in their endoscopy because they say, oh, you don't have to mark anything for endoscopy. Well, you still have to check that there's consent. You still have to think about any problems that you may have. Right? And then the failure to follow up. When I'm talking about follow-up, I'm talking about, how do we audit to make sure that there's compliance? How do we audit in terms of quantitative, which is looking at how often it's done? So how often the sign out, time out, and sign out are being done. We find out that many hospitals, you will find the sign out is done, the time out is done, but the sign out is not done. And research has shown that, in looking at papers that have been done, the numbers, the average sign out compliance is about 33%. And the sign out is a very important part because that's where you discuss what could we have done better, what didn't go so well, and document it for future learning. Okay, so it's important to do that audit. You do quantitative audit and then do the qualitative audit. Come in and see what is happening. Unfortunately, many teams use the checklist as a tick box exercise. So they've asked us to do this, tick, 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 tick. I've seen myriads of ways in which it's been done. I remember going to a hospital and, waiting outside the door for them to complete the timeout. And then I got into the theater and asked the person who did the timeout to let me see the form. By the time they finished the timeout, the person had already ticked off sign out as well. Then also, I remember going into another hospital. Every hospital I go to assess, I watch a surgery if I can. If they do have a surgery during the period of my stay there, I will try to observe one. And I remember observing one, and during the timeout, of course, that day, the anesthetists were off doing their own thing, and this poor nurse was trying to get everybody's attention. Everybody was off doing it, and I thought, right from the onset, you've defeated the purpose, because the purpose is for everybody to stop and have a conversation and communicate to say, how are we going to do this? Are we ready as a team to do it? What are we anticipating? Okay, so that didn't happen. But what then really got me speaking up, because usually I would not speak up, I'm there as a silent observer and then I'm going. But what got me to talk was that the nurse had said, do we anticipate difficult intubation? And the anesthetist said, yes. And the nurse ticked it and then, just moved on to the next question. And I said, hold it. You're anticipating difficult intubation? They said, yes. Are you prepared? And then everybody stopped and were looking at me. Where's your difficult intubation tray? The reason why we're asking this question is so that we can be prepared. It's not just a tick box. Okay, so when we use it just as a tick box exercise, management is going to kill us, we have to have 100%, then we will have issues. Of course, the stopping is one. So modifying the checklist for our purposes is very important. This is one from the Hammersmith Hospital that has been modified for their interventional radiology area, and you can see that most of the elements are in there. But you will then see where they have specific things because of things that are aspects that are important to interventional radiology. Is there nephropathy? For instance, you can see that there. They're asking if there's nephropathy because that's important for the dyes they use, right? So is a defibrillator tested? That is for them. It's not everywhere you ask about a defibrillator being tested, but they have customized it for themselves. Spot the difference. This is the one I was talking, this is something like what I was talking about. Here's this poor lady trying to do the surgical safety checklist, and the surgeons have, gone on merry way. Now, this surgical safety checklist on the left will be filled out, but have they really checked? So in an organization like this, you will hear people saying the surgical safety checklist doesn't work. Well, because the spirit of the checklist has not been followed. Okay, so what we would like to see is what you have on the right, where everybody stops and they are listening and participating. Okay, so I've already talked about some of the errors that we observe. It's not just a checklist. Don't lose sight of the why. The one-man show, where the poor nurse or anesthetist or somebody is the one ticking off whatever it is, and there's a failure to stop. When there are identified issues, we need to follow through. I've been part of investigating an incident where, some major equipment had malfunctioned during a surgery. And in doing the root cause analysis, we actually found out that in a previous surgery, that equipment had malfunctioned, but nobody had taken time to write it out and make sure that the equipment was, again, looked after before the next time it was needed. So failure to follow through on these problems is an issue. Non-standardization of the surgical mark. Most hospitals, or no, don't let me say most, many hospitals will say, oh yeah, the surgeons do sign. And then you ask them, what's the standard sign? What have we all agreed to use? And they're like, it doesn't matter, the surgeon signs whatever they want to sign. But then that can be confusing. Okay, so failure to standardize, is an issue. Sign out not being done. You haven't completed your surgical safety checklist if you don't do the sign out. So what are the strategies to increase the likelihood of success? One, active leadership and identification of champions, right? Champions in your organization. I remember, one of the best places I found, it was an anesthetist who was really respected, and all the surgeons liked to work with him. He was the main champion. And if you don't do your surgical safety, he's just not going to go on. So if you want him to anesthetize your patient, you're going to have to do the timeout, the checklist. So over time, it became a culture. Early engagement of the staff, proper education and training about how to do it, why we need to do it, what do we need to check, why do we need to check it, is very important. The multidisciplinary involvement, oftentimes it's the surgeon and the leaders, or a nurse, a concerned nurse and the leaders. It has to be multidisciplinary. We have to coach people. Go observe your team, see how they're doing. At the end of observing, provide feedback. So we've done this well, we need to do something different. Local adaptation, ongoing audit, like I said, monitor and record the nice catches. I think this is very important. Saying, if not for the surgical safety checklist, we would have run into trouble. Or we caught this and we caught that. When you provide that feedback to the staff, that is usually very helpful. Okay, and here are some of the interesting tools I found. Getting people to pledge that they would use the checklist is very important. Have a big show and get everybody to pledge. In some places, there's a sign out sign at the back of the door. So you can't, it would remind you as you're trying to open the door. So as the surgeon is leaving, before the sign out is done, they've seen, if no sign out, no out, right? And then you have things like sign out or timeout towels. We don't start until we've done a timeout and things like that, okay? So I will move on very quickly to the second one. Zinat has also already spoken to us about effective communication. And you can see here, just like she said, effective communication in this study by Joint Commission over 11 years pointed out communication as one of the leading causes of sentinel events. And out of those, about 80% had inadequate handover as a factor, 80%. Okay, so when you're talking about handover, please remember that handover is not just doctor to doctor, nurse to nurse, like Zinat said. It's at different levels, different wards. So if you're moving a patient from ICU to the inpatient wards or regular wards, or from regular wards to ICU, from the operating theater back to the ward and all that. And when you discharge the patient, you're actually handing over the patient to themselves. So don't forget that, even though we're not talking about that at the moment, don't forget that you're handing the patient over to themselves. So you need to make sure that they have all the right information to be able to continue their care at home, okay? Zinat showed us the S-bar. The one I want to show us now is what you call the IPAS, because you want to make sure that you are transferring vital information about the patient. It's not just writing things down. It's about transferring vital information. And this is IPAS, talks about the illness severity, to give the patient summary, action items, situation awareness, and then synthesis by the receiver. That is, the receiver then kind of verbalizes what they understand, and then, before you can move on. When we're talking about effective communication, one of the main areas is the verbal orders. And to be able to implement verbal orders well, these are the following things that have been advocated for. Number one, limit verbal orders as much as possible. As long as the person giving the order can write, let them write. I know that there are all kinds of cultures that we see. So, consultants going on ward rounds with the younger doctors, and the younger doctors are the scribes. If you're going to do that, then follow the principles of verbal orders, because that's a verbal order, right? Develop guidelines for requesting and receiving test results such that everybody is on the same page. It's standardized. Identify and define critical tests and the values. So not just the test, but you have to have the values. One of the things that we see is that many organizations take all abnormal results as critical results. There are the pros and cons for that, okay? Because you can get critical value fatigue, when they're calling you all the time for every small abnormality. So consider how that works for your organization. You need to identify to whom and by whom critical results can be reported. It's not just everybody. Can you report your critical results to your ward clerks? Is that acceptable? Or is it just the nurse? Or is it the doctors and the nurses? Think about your organization in terms of the why, the patient safety, okay? And monitor compliance. Furthermore, it's important to remember that write down, read back is the advocated method, not repeat back. The difference between read back and repeat back is that you have to write something down to read it back. But to repeat back, it can be, I'm just taking the instruction, I'm keeping it in my head because you're telling me now, I repeat it back to you, but by the time I get to where I'm going to write it down, I'm writing down something different. So please note, it's not just repeat back, it's read back, okay? Now, pitfalls of implementation that we've seen will be: one, narrow definition of critical results to mean lab only. Many organizations have critical results for their labs. They don't have for radiology. They don't have for ECGs. They don't have for EEGs and for ultrasound and for bedside. Even for point of care testing, you have to have the critical results for your point of care testing, right? Because you do point of care testing, you check the sugar at the patient's bedside. Does it matter whether it came from the lab or from the bedside? The fact is the patient has this really elevated blood sugar. What should you do about it? Think about, why do we say you report back critical values? It's because those values are such that the patient's life is at risk if something is not done. So it doesn't matter the place where the result is generated. It just matters that we have found the result and we need to do something about it. Non-inclusion of staff in the patient care areas, right? So the lab knows what those critical values are. The people who are receiving the care do not fully appreciate what those critical values are. You haven't trained them to know how to respond, okay? Then you train your technicians. Your ECG technician knows how to do ECGs, knows what to look out for and call the values. What about the doctor on the ward or in the ER who is doing ECGs? What about the nurses that run ECGs in your outpatient? Do they know these values? So ensure that wherever the test is done by whoever, they all understand about the critical values and how to report. Okay, now classification of critical results in terms of what the doctor says it is. So if I ask for a start test, then that is a critical result, rather critical test, rather than it being based on the impact of the result on the patient. Failure to establish response times for physician notification, right? So we see critical results, it's written, somebody calls the ward, but there must be a time in which you say something has to be done for this patient. I've seen organizations that say when you have a critical result, action must be taken, not just reporting it back, but action must be taken on that result within 30 minutes, because that is the essence, providing the care. Now, failure to confirm, to read back and confirm. So I read back something. You say something to me, I read it back to you. You need to say to me, yes, that is what I said. And the last one is failure for physicians to authenticate. So when physicians give verbal orders by telephone, they are meant to go back in and check that the orders were written and carried out properly. Now, this is a legal issue that many of us don't realize. When somebody has written, Dr. Yewumi said to give 50 milligrams of something and they've done it. That means I gave the order. I am responsible for it. If I do not countersign or correct, I have said I agree. So for even just to protect my license, I need to check what's been written on my behalf and to catch any errors. So physicians must go back and review and authenticate any verbal orders that they give. Okay, so making sure that all tests are included in critical results reporting, bedside, MRIs, echo, where you have technicians doing all that. I will not read through all this, but the Joint Commission has provided what they call 8 tips for high quality handoffs. Okay, you will receive this. They are really good tips for implementing the good handoffs in your organization. Finally, just to reiterate the courses that we have developed and put on the OLC platform, for safe surgery and effective communication, I will talk about, and even high alert now. On the left, you will see the kind of things that you will get there, how to engage your staff. That's one question we get all the time. Everybody's talking about, how do I get my staff to do this? How do we even engage staff? What should we be saying? On the left, you can see it's part of what you will learn in those courses. How do you monitor? How do you monitor compliance? What kind of indicators do you use? Okay, that you would also find in the courses, how to start. And you will find some checklists that would help you. For effective communication, you will be looking at why you need to improve your communication, how to form a team. What are some of the standardized tools? We actually have prepared for you tools that you can download to use. So you will find you'll find the courses very interesting and very useful. And above all, very practical to help you establish all this in your organization. Same for high alert medications. You will find the how and the why in there. Okay, thank you very much.
Thank you very much, Dr. Ajibike. This was also very useful, great presentation. And just a few takeaways from what Dr. Ajibike just said. So speaking about safe surgery, of course, there is resistance. Unfortunately, that's the reality we're living in. And every surgeon, first of all, says, well, I'm a qualified professional. This never happens to me. I never leave an instrument inside the patient, so I don't need a checklist. That's common answer that we hear. But unfortunately, real statistics shows that foreign objects are quite often, unfortunately, found inside the patient. And in this case, same surgeons say, oh my God, this couldn't have happened. So the safe surgery checklist is basically a very powerful instrument which helps to prevent such cases. Because, again, just for your information, nobody is insured against a mistake. Everyone can make a mistake. If you know the first man who went to space, Gagarin, he was sent there by a very famous globally person named Sergei Korolev. He was living in the USSR, and once he had some health condition, and he was operated in the best hospital of the country by the best surgeons. And he died at the age of 60 on the operating table as a result of multiple mistakes, because basically in that surgery, everything that could go wrong went wrong. And the root cause analysis that was performed, the roots were actually problems with the intubation, which were not identified when it was required. And when they were identified, nobody was prepared. So this was exactly the case that Dr. Ajibike was telling you about preparing for complicated intubation, which is included into the safe surgery checklist. So safe surgery checklist, as you know, is available online on WHO website. Common question, should it be just downloaded and used, even if you disagree with certain points there, or should it be adapted? Yes, it should, it can, and it should be adapted to the local specifics because different hospitals have different conditions. And there are even multiple guides on how to adapt the safe surgery checklist. This is on safe surgery. On effective communication, again, same takeaways. Please identify moments when you need to control the communication. Please limit use of verbal orders to only emergency situations, because less verbal orders, less risk of mistake. And also develop your own processes which fit into your departments, to the specifics of your staff, to the specifics of the services you provide. Develop your own processes together as a team. Before we move to our very exciting session of question and answers, by the way, we are staying a little bit longer today, so thanks for being with us, because now we will be discussing your questions and answers. But before we do this, I also wanted to make one comment on the training modules that Dr. Ajibike already demonstrated to you. So all the questions that we discussed today and that our experts discussed during the presentations and a lot more you will find in our training modules. And if you are a healthcare quality professional and you have to do training for your staff, or you are a department head and you also need to increase awareness for your staff, you're welcome to use these modules for your in-house training. You can ask your staff to pass this training and they will get a certificate, and it will be much easier for you to create this culture and also to implement it. It will save your efforts because, as Dr. Ajibike said, there are multiple tools and PDFs and samples of written documents which can be downloaded, printed out, and you can start using them already tomorrow. And now we move to the section of, to our part of questions and answers. And once we just discussed the safe surgery checklist, the first question relates to it, is very practical. Actually, who needs to be using the checklist? Which is the most efficient way to do it? Which staff should be in charge of filling in the checklist? And maybe also some more tips on how to use the checklist. Who would like to start?
Well, yes, Lina, please go.
Go
So
ahead.
let's hear it from you.
You know, as we all have been talking about, looking at a process as a multidisciplinary team, and that's the same spirit I think we should keep in mind when we are looking at this IPSG. Safe surgical checklist is not about a physician, a surgeon or an anesthetist or a circulating nurse or a scrub nurse. It's the whole team which is accountable if something goes wrong. And that is what we need to look at. Who does it? The champions need to be identified, and as Ajibike talked about, an anesthetist, a respectable anesthetist becoming a champion in an institution to really understand what the checklist is, what needs to be done, what doesn't need to be done, what is duplication, how do you work on it, and so on and so forth. That champion could then be the leader who can then work with the surgeons and everyone, and then the checklist can be implemented. The actual filling of that is at different levels, being responsibility of different people. In the sign in, the recovery room nurses and the surgeons are responsible about the site marking, etc. In the operating room, it is sometimes they are anesthetist technicians, sometimes they are circulating nurse, sometimes they are also trainers, training people in training. It all depends on your organization and how do you work. My response to this would be, do not forget it's a multidisciplinary team. Everyone has equal accountability of this, and absolutely it should be done by identifying a champion and then agreeing to who does which part, and then who signs and countersigns, and so on and so forth. So that's my input on that.
Thanks a lot. Dr. Zinat, Ajibike, you wanted to say something, or shall we move to the next question?
No, well, similar what Dr. Zinat has said, it's multidisciplinary, because I'm seeing, in the comments, we have to talk about who is responsible for the checklist and all that. The who may be in terms of collecting data, but who is responsible for the checklist? Everybody who's going to work on the patient is responsible for the safety of that patient. So we may ask one team member to read it out, but we must all realize that we are all responsible for the patient. I remember one of the hospitals where I worked as a junior doctor. if I were to recommend now, I would recommend the matron. The matron was so in charge of her theater that even the surgeons had to, they trembled a bit when they came into her theater. Her word was law, so she would make things happen. So it depends on your organization and who the champions are, who would make it happen. But most importantly, we remember that the safety of the patient is the responsibility of everybody.
Thanks a lot, Ajibike. This is very valuable input. But once we already started to discuss surgery, actually a question which is mixed on the two goals. One is effective communication and the other is safe surgery. That's verbal orders in the operating theater. Any tips on doing it safely?
So verbal orders in theater in emergencies is one of the how do you put it, exceptions that is often talked about, because when things go really awry, it may be difficult for you to stop and write things back, but you must try to repeat back, and you will see, you see that with the pilots. Give 1 milligram of adrenaline. 1 milligram of adrenaline, 1 milligram of adrenaline being given. Give me 2O suture. Okay, here you go, 2O suture being given. That doesn't take a lot of time, but we may not require write down at that point. But please, that is the exception to the rule, and is only in those situations where you really cannot do it safely. Again, the safety of the patient comes first. So we're not asking surgeons to take off their gloves and go and write down. But you must then, implement all the other things like the read back, repeat back to make sure that you have safe communication.
Thanks a lot. Dr. Zinat, you wanted to say something on this?
No, I think.
Okay.
I think.
Sorry, because I saw you're unmuted. Then we can take another question.
No.
And another question relates to the critical results, specifically by the bed of the patient. So how should they be recorded? At what point? Who checks this recording? And also maybe some other tips and advice you can give on how to make it in the most efficient way. Recording critical results, especially if they are not in the electronic medical record system, especially if they are done at the bed of the patient.
So you know what? I think we should look at critical results in totality. And if the institution decides that this is the logbook which we will use for critical result reporting, then let it be this logbook, whether it's the critical result is coming from radiology, from lab, or from the point of care testing. So if a nurse is seeing a patient's glucose is 400, and 400 is the range, whether lab does it or she or he does it, then that is the policy. Let's not complicate and confuse staff by putting multiple forms and multiple places to write and multiple things to do. Critical reporting is critical reporting, period. Whether it comes from any department or it comes from point of care testing from a nurse or a technician in case of an ABG and so forth. So that is what my view is, to keep it simple, to keep it consistent across. Now, once you have decided, and it's your institution, you need to decide what is the best available format you want to do. And if it is this book, everyone would write in this book. And once you write it, then you take it to the next step, and who does what, how fast did we inform the doctors, and so on and so forth. So that's my view about how and where do you document. Keep it simple, keep it consistent, but just not stick to where you document, but go beyond it. What do you do about it? I think that's more of an important question of how do you take an action about a critical reporting.
Yeah.
Thanks a lot, Dr. Zinat. Ajibike, you wanted to say something? Thanks.
Yes. So what I have seen that seems to work for many hospitals is, because you don't want to be moving around. So when you have electronic records, for those who have electronic records, There's a form online. Everybody knows you go click on critical results and then you fill out the results. But for others who are using paper, they have lab logbooks. And, I see that now, it makes me quite happy. You have the lab logbook. You ask them, where's your critical result book? They go, they pick up their logbook and they say, this is it. For radiology, you say, where is it? No matter what kind of radiology test it is, everybody knows that it is this one logbook. And then for point of care testing, everybody knows that if you do a test on the wards, don't forget to write it because you say, oh, when I get to the lab, I will go and write it. There's almost like a register. Oftentimes at the nurse's station, all critical results must go in here at the minimum, So that's that one. But also too, staff shouldn't forget that because you have it in the book, the clinicians have to write it down. When you get the call, that write down ideally should go directly into the medical records, whether it's on paper or on the electronic medical record, because there's also the problem of transcribing. So as much as possible, you want to limit transcribing if you can, but that's not always possible because you may be on the move when somebody calls you and you don't have the medical record right there. Still stop with the paper you have in your hand, write it down, it's better than nothing, and then move to do something. But please remember to write it back in the patient's report, patient's medical record as well.
Thanks a lot, Dr. Ajibike. And the next question is actually for Jackie. And it relates, Jackie, to the two cases that you described in your presentation. So now we are offered to do a little bit of root cause analysis thing. Basically, would this situation be different and would it save the patient's life and make the patient's condition better if in the first case that you described with the baby, the responsibility of midwife was the responsibility of the nurse? So if we had a nurse instead of the midwife, would it help? And the second question relates to the second case. Would it help if the pharmacist who was distributing the medication double checked? And is it the failure of that level, the failure of the pharmacist, or maybe at some other level there was a failure as well? Can we just reflect on this a little bit? Thanks a lot.
Yeah, thanks, Julia. They're important questions, but I think there's a little touch of blame creeping in. That a midwife, a nurse, a neonatal nurse would be better than a midwife. And I think that's a risk. And particularly in the areas that I work in Africa, we don't have those specialists necessarily. So we've got to make sure that whichever professional or semi-professional is looking after a patient is as safe as possible. I think that differentiation is really difficult. I think it's more important about not necessarily who was looking after the patient, but how well trained is that person and how well resourced is the environment in which that person is working to ensure they can be safe. Because I'm not going to say a nurse is better than a midwife or a midwife is better than a nurse, because often we do not have the choice. We're not blessed with that. With the second question, I think the pharmacist plays a critical role in prescribing and checking. And I've worked in hospitals where the pharmacists do a daily or twice daily check on the prescriptions to ensure that what the doctors have prescribed is absolutely right and there are no contraindications between medication and such like. But again, we may not have that luxury. In the situation where this happened, the pharmacist may not have been available, and there may not have been enough pharmacists in the hospital to do those checks. There's a ward stock of medication, and the doctor prescribes and the nurses use the ward stock of medication. So I think we have to be very clear that particularly in the aspects of safety, we're not always talking about highly sophisticated hospitals with all the resources that they need, that they should have, that they want. And I think we've got to make sure that where we don't have the benefits of those additional professionals, we have mechanisms in place that ensure that the staff that are there can be as safe as possible. And I think I made the point, and both Zinat and Ajbiki have emphasized it. This question of being able to challenge what another professional has done in a constructive way that says, as in the surgical checklist, exactly the same should be as prescribing. Doctor, are you sure this is what you should? Because I think this is for something else. So I think that ability to challenge, that nobody's too important to be asked. Nobody's too important to be challenged. And we've got to respect each other. And for the sake of our patients, it's not because I'm more important than you or whatever. It's because I care about my patients that I will challenge and I will check.
Thanks a lot, Jackie. This was a great comment. I really do agree that everyone who is working, who is dealing with a patient inside the hospital, just has to ensure same level of patient safety. And also, a great comment relates to shame and blame culture. We shouldn't blame specific person, specific staff member for not being good enough because it's maybe not that high position, and that's why the mistake took place. So speaking about shame and blame culture and resistance of staff to speak up, etc., we receive multiple questions today, and we are planning to devote a discussion during our next webinar about it, and we will send us an invitation in a separate letter. So you're welcome to join, and we will be talking only about how to overcome the blame culture and lots of issues which are connected to it. So second point before we move to the next question I wanted to make is actually relating to the questions that we receive. We receive so many questions today, and thanks a lot for staying longer with us, and thanks for sending your questions. But unfortunately, of course, our time is limited and we will not be able to discuss it all today during our webinar with our experts. But we will definitely move your questions to our community of practice, and there we can continue the conversation in comments with our experts. So you are welcome to join our community of practice, and you will definitely find answers to many of your questions. So next question is a more generic one, the role of policy. Speaking about the 3 international patient safety goals that we discussed, lots of information can be found on the internet. Seems that the idea is pretty much straightforward. Do we need a policy for each of them? Tricky question.
Do you need a policy for that? Let's think through this question. What is a policy? How do we define a policy? A policy is really a document which is easily available for our staff, so they can read it, we can review it, and we can reinforce the elements of that policy. I agree, IPSGs are not rocket science. They're simple to implement, understood, and worked, but they are not being done that way, as we know. That's why they have become international patient safety goals for us to do it. So what does a policy mean? And why do we develop any policy? Importantly, IPSG, it's a tool for communication. It's a tool to ensure consistency. It's a tool to monitor our policies with our practice to see, are we performing the way we should be performing? So the question of should we have a written policy is something you need to think about. In my view, I have seen a wonderful checklist, a wonderful surgical checklist, which is being used for within the operating room and external operating room. And that form, the checklist, has written the do's and the don'ts, who will write, who should fill, and so on and so forth. If that form is your way of communicating with your staff, that's your policy. Sure, you can convert it and make it into a write-up and this, that, and other. So once again, the use of a policy is important, absolutely important for you to document for many reasons, which I alluded earlier. Is that a lengthy 15-page policy which nobody wants to now read and it's a dead document, or is it a living document in a shape of a form which you are implementing, you are monitoring, you are educating your staff for? Is something you as leaders in your organization need to decide. So that's my view about policy. And I agree, writing policies for the sake of writing is also quite a waste of time for all of us. So I would leave, that's my view, but my colleagues can add their views.
Thanks a lot, Zinat. Jibiki, Jackie, do you want to comment on the policy importance? Well, thanks a lot anyway. Jibiki, are you talking? Are you talking or muted? Okay. So yes, I agree that policies. Sorry, Jackie. Yes.
Please. I was muted, but I absolutely agree. When we do accreditation visits, if I find policies on a shelf in a very shiny folder that don't look like they've been touched, I'm really worried. And if they've got CASAS's name on them, I'm even more concerned. I want to see things that have been read, that have been touched, that are simple, that are easy, and preferably on one side of A4 or an electronic format, because you haven't got time to digest great big long documents. So it's got to be relevant and it's got to be workable. Then a policy is fine.
Thank you so much, Jackie. That's a great statement, because actually we also say during our assessments, when we work with medical facilities, we always say that if it's not written, we can see that it doesn't exist. Why? To ensure consistency, to make sure that in case staff leaves, you have same procedure. It's not dependent on the human factor, because it happens. Sometimes nurse is doing a great job, but then she has some personal issues, she leaves, and you have to build the whole department in you. So in order to avoid that, develop a policy. Policy is critically important for every area. Can it be international patient safety goals? It can be medication management and use. Policy is critically important. And we have devoted a whole webinar session on development and implementation of policies, and they are available in recording on our IFC page. So we had a wonderful discussion today, and I wanted to remind you once again that we can continue a discussion of the questions that were asked today to our experts in our community of practice. We already shared the link. It's on Facebook. It's free of charge, of course. You are welcome to join and have knowledge sharing sessions. You can even, if you are proud of some solutions which relate to international patient safety goals implementation, you're welcome to share. All the members of the group will maybe learn from you, and that's a great thing that we can do. So as I already said, we will separately inform you about the upcoming webinar, and when we will have a webinar on the overcoming the blame culture, which is a great issue, very big issue, and we received a lot of questions today, and we will include them into our next webinar. Please do not think that we didn't notice them. We noticed every single question. So Natasha, did you want to make any comments before we conclude today?
Yes, I always want to make a comment about how important your feedback is. We were looking through the chart. I mean, all of us were looking through the chart every time there was a new line there, and we tried to see what is important for you. We tried to see how we can respond, how we can provide an answer, how we can help you. And so please let us know through submitting feedback, either through survey on exit. There will be 3 questions, and please answer them and type whatever comments you want to type, or send us an email. We will send you an email tomorrow, so you can send us an email back and tell us how this was. So your important is what drives our effort and our IFC IQ healthcare webinars.
Thanks a lot, Natasha. So thanks once again to all our wonderful experts today. Thanks for sharing your personal experience, lots of practical tips. It was super valuable, I believe, I hope. Thanks a lot to all our participants who stayed longer with us, and it means that we hope that you find our sessions useful. and we wanted to express our gratitude. Once again, I wanted to mention that in our online training modules, you might find lots of answers to the questions, because today we received lots of questions which relate to specific tools, various checklists, policies, procedures, and forms which relate to the international patient safety goals that we discussed today. Please explore our online training modules, which are also free of charge, and most likely you will find lots of useful materials ready to be printed out there. So thanks a lot once again to everyone. It was a great session, and look forward to see you next time. Bye-bye.
Thank you very much.
Thank you,
all.
everybody.